Hello, everybody. My name is Emeritiana Eshiebor, and this is my DMP final presentation. The title is Incorporation of Palliative Care Screening Tools by Nurses. My committee members, I have Dr. Isa Moyer, and for my second reader, I have Dr. Jennifer Brownworth, who is my professor for 705. My community person, I have Ms. Mary Hum, the Director of Palliative Care Consult, and Ruth Blackwell, the Director of Quality and Care Improvement, and Christina Bowman, who is also a Palliative Care Director as well. My background. The aim of this project, why palliative care? Why COPD patients? Why ICU nurses? The goal was we saw that nurses in the ICU were underutilizing the palliative care screening tools. The goal for palliative care is to come in and provide symptom relief for patients with chronic conditions that are frequently being frequently being hospitalized. But we noticed that the palliative care screening tools were not being used as frequently as we would want in an ICU settings. Hence, the goal was to incorporate this palliative care screening tool by educating the nurses, showing them how to utilize it, to where to find this tool. This tool is already embedded in the EMR. The goal was once they see a patient that has chronic conditions like COPD that are being frequently rehospitalized, they have to go in and assess the patient. They have to go in and screen the patient. We have a screening tool which will be shown in the next slide or two on how to search for this tool and make sure that, hey, how is this patient functioning? Does this patient need help? Are they being frequently hospitalized for the same symptoms? How can we control their symptoms? There's only one way. There's only so much we can do in a hospital, but what more can we do? Can we incorporate more care, like incorporating the palliative care team into this patient lifestyle to help better manage their condition? The significance of this project was we noticed how COPD is being globally, it's one of the third leading causes of death. A lot of patients with COPD are not able to properly manage their conditions, and being that, so they come to the hospital for care majority of the time, and most of them experience symptom burden, financial issue, because they're not able to manage their condition. And with palliative care screening tool, once it's used, it's the goal for the nurses to actually go in that EMR, find the screening tool, and screen this patient. You don't have to wait to the very end of life to screen patients or to intervene with palliative care. But once it's utilized early, palliative care can come in and also ask the patient, how can we help manage your condition? What referrals can be made outside of the hospital? What do you need? What supplies do you need? How's the oxygen supply in your house? What social worker or what needs can be made? So once this palliative care screening is being done, that's when palliative care consults can come in to help these patients. 31% of patients with advanced COPD has less than 1 year of life survival, as seen in Rennick and Johnson 2023. Also, when Kitchler et al. 2018 utilized this palliative care screening tool in their study, they saw a 35.6 increase in palliative care consults when they utilize palliative care screening tool. Review of literature. During this project, my literature searched. I went through CINO, went through the whole database. The goal was to search. My search term used was palliative care consults, palliative care screening tool. I also had to narrow the search. I looked for adults with COPD conditions, and I found numerous articles, over 330. Out of the 330, 15 of those were reviewed. I had to group them because we had so many worldwide, and then finally narrowed it to 11 primary articles, which helped me during this whole process. Most of the articles talked about how important early screening was, how important early consults was, and how important that with individuals with chronic conditions, palliative care has been shown to help these patients. Some of the screening tools utilized in some of the researches like Hutchell, Kitchler, lab inversion. They utilize the CAV-CU ICU, the IPAL ICU. They saw how effective it was when it was implemented. Some of the literature work also found out that most of the palliative care tool wasn't utilized due to lack of education, due to lack of constraints. There was also provider biases, how some providers were not able to know how to initiate it early, or they had to wait to the very last minute. Some of my literature. And also how important early screening is, and it can lead to early consults. Theoretical framework. For this project, I utilized Catherine Kolchaba's comfort theory. A lot of nurses know how important it is for nurses to be advocates for their patients. So this comfort theory basically summarizes how if nurses help patients meet their needs or identify their needs, such as, oh, my patient has COPD, or oh, my patient has a chronic condition, and they look at the screening tool, oh, they qualify to be screened for palliative care. Oh, palliative care can be utilized for this patient. So with Katharina's theory of comfort, once nurses implement that in their daily work life and activity, they can also implement palliative care screening. This comfort theory is also holistic. It also helps patients manage their comfort better. It also helps with supporting symptoms, help them with decision making, and it's also goal oriented. Yes, as nurses in the hospital, we can only do so much, but when this patient leave, what happens after that? That's when palliative care also comes in place to make sure that they ensure this patient has the necessary staff to help them manage their conditions, comfort for them. This is my timeline for my project. I started this whole planning phase from April 23rd, 2023 to September 23rd, 2024. During this first planning phase, I had to gather my assessment, collaborate with the palliative care coordinator, Miss Mary, also the director of the quality head, Miss Ruth, and the MICU manager and ICU manager. I also talked with the charge nurses. These are my planning phase, introducing them that, hey, I'm going to be coming around. I need to talk to you about palliative care. They need to screen more. My IRB approval date, since this was a quality improvement project, I did not need IRB approval, but I submitted the whole process as well and the facility during April to September 2024. And then for my developmental stage, as well as my education and implementation, I created a poster board. So with the approval of my committee members, showed her what the poster board is, went around the nurses' units, day shift, night shift, integrated with the ICU, neuro ICU nurses, the medical ICU nurses, told them how palliative care needs to be implemented for patients with chronic conditions like COPD. We noticed that even when the palliative care coordinator sends the nurses messages to screen their patients, due to the time frame and how hectic the ICU is already, some of the nurses also forget to screen the patient. The palliative care screening tool is already embedded in the EMR. The goal is for the nurses to just go in and screen their patients. So during my education phase, I asked some of the nurses, show me, how do you find this? Where do you screen this? What is needed for this patient? So this was my whole timeline, my pre-intervention phase from October to December, and my post-intervention phase, January to March. My method and design. For the design, I did a quantitative exploratory design, being it a retrospective chart. This is already something that's been created. I didn't have to create the palliative care. It's already in the system. The goal was to make sure that they are being used so we can get more palliative care consults, because the palliative care consults haven't been getting a lot of consultations. And with this design, the aim is to measure consult rates, to measure the screening rates, to measure the COPD patients that are being in the hospital. With this quantitative exploratory retrospective, we can compare data, the pre and post intervention. I had a whole 6 months period to use this data and pull a lot of information from the EMR and compare a whole chart. So this was the best design for my project. I educated the nurses, screened them, I provided snacks for them to engage them in the communication. So that was very interesting, and that held my method and design for this project. Here is a sample of our palliative care tool that's already in the EMR. The goal is for the nurses to go in and screen the patients. And like here, you can see criteria for the patient. Is this patient a candidate for palliative care? Do they need more screening? What is their score? Is it more than 4? If it's more than 4, yes. Go ahead and put in that palliative care consult. Go ahead and notify that provider. Go ahead and notify the palliative care team so they can come in and assess this patient's needs, assess this patient's symptom burden. Do not wait till end of life. It can also be implemented early in care. My population, as mentioned, we did in an adult ICU, neuro ICU, medical ICU for patients with chronic conditions like COPD. My inclusion criteria were the nurses, ICU nurses older than 18 years old. They were 20, 21, 30 varieties of age, different cultural background, and it was good to engage with them because they saw their fellow coworker and their fellow staff member talking about something that we see so often. So it was good to to talk with them, and they were excited about this project. My sample size, I got over 150 palliative care screening together with the consults and the COPD patients. We got all the total number within that 6 months period. For my data analysis, I used a statistical test. We did a Z-test. Z-test is better when you're trying to compare two population. When I spoke with the statistician, Mr. Pals, he explained how I needed a number of over 150 number of patients screening both palliative care and consults and COPD patients, so that way I can compare my data, and the data that was collected with the screening, the palliative care, and my COPD. Being that I needed a large size, hence the Z-test was needed. Here are my results. Starting with the screening tool, I have here below the charts that were reviewed pre-intervention. We saw only 15 was right here in the bottom. Only 15 of the charts were reviewed pre-intervention, but post-intervention we got about 62. So as we saw from a 90% to 81%, that's a huge number. And then compared to our post-intervention, you can also see there was only, from the chart the review went from 15 to 38. And then we saw like 87 of them was not reviewed. Yes, 87 is a large number, but looking for where we came from 15 to 38, that is a large number of screening tool that was changed from the education and the implementation phase. More work can still be done. It's not perfect. We can still educate more nurses and show them where to find the screening tool. But going from 15 to 38 between October, December 2024 to January, March 2025, it's a huge number. And as the statistic was 1.7, we had to reject the null hypothesis. For my palliative care consults, we had pre-intervention, 7 of it, 7 consults, 46.7 pre-intervention. Post-intervention, we had 17 consults, 44.7% increase. I know it's not much, but within that short time period for the ICU, neuro ICU, medical ICU, we went from 7 to 17. The Z statistics was negative 0.1. We did not reject any null hypothesis. We used, again, upper Z test because we can compare the two independents. Also, for my COPD patients, being that we had to narrow it down to COPD diagnosis only, we only saw 3 patients that had COPD pre-intervention. Post-intervention, increased to 5 patients screened. So we went from 50% to 83.3%. Although being that 3 to 5 is a small number, remember we had to narrow it down to a condition being COPD. We do not reject any null hypothesis for this result, and we had 1.22 for us statistics. My limitations for this screening tool, I encountered a lot of limitation. One of them being the short time frame, 3 months pre, 3 months post, 6 months in total. And for future practice is to engage in larger time, maybe a year or two, to compare prices, to compare the numbers. Also, my small number being my COPD patients were only from 3 to 5. We didn't get as much as we would want, but we also saw an increase in the palliative care consults and palliative care screening tool for chronic condition. Also, some other limitations when I engage with the nurses, they wished that they got alerts that, oh, we need to go screen right away. Some of the nurses said they even got text messages to go and screen, but due to how like their schedule on the ICU unit was busy, it's not like mandatory. You have to keep reminding them. But that's one of the limitations we saw. But if it's an alert and you can't move to the next slide till you screen this patient, then they will go ahead and screen the patients. I also saw another short time frame physician follow-up. They needed to make sure that, hey, this order was placed right, go ahead and consult palliative care. So these are some of my limitations. Discussion for this project. As we can see, this project demonstrated a positive impact. A lot of the nurses were excited. I don't know if it was the candy, but they were also excited in seeing the project and knowing that, yes, this patient needs it. Patients with chronic condition need palliative care consults. Palliative care consults can help, because when palliative care team come in place, they can help with symptom burden. They can help manage this patient condition. They don't have to wait to end of life. We can start early, and then we don't see this patient frequently. And even the patients get exhausted because this affect their financial health, they affect their family, it affect their lifestyle as a whole. But with palliative care in place, they can help. Okay, what can we help outside the hospital? What can we do to help manage your condition better? Another discussion for this project was the early intervention. As mentioned, we don't have to do only neuro or medical ICU. You can start as early as when they come into the emergency room. Can we screen this patient for palliative care? So these are some of the discussions for this project. Also, we noticed there was an improving consult rate for not just COPD patients, for chronic conditions. So hence, palliative care team and palliative care consults is needed, and literature also shows that. Implications for practice. For practice, the ICU workflow is already hectic enough. The goal is to quickly send an alert to these nurses. Go ahead and screen your patients as soon as they come in. Do not wait to the very last minute. Collaborate with team. Have education on the floor. Education nurses educating the ICU nurses and other nurses how to utilize this palliative care screening, because the goal, it helps with better symptom management, it reduces patient suffering, it also helps the patients as well, save health costs, fewer readmission rates, and also with nurses on the floor, it can also help with critical conversations. And the goal is, hey, our patients is being managed carefully. They're not suffering. We're seeing like they're being comforted well. With palliative care in place, they can also help them as soon as they get discharged, when they leave, even when they transfer from the unit to another unit or to step down. The palliative care team is also following them. But once this isn't in place, or this isn't initiated early, then the patient just goes home and comes back with the same symptom, and there is no care follow-up. There's no palliative care follow-up with them. In conclusion, for this project, we saw a successful increase in palliative care. Not just the screening, we also saw palliative care consults being placed. So Hence, palliative care plays a huge role in patients with chronic conditions. And when it's being utilized early, when nurses utilize the screening tool as they're supposed to, it's already embedded in the EMR. Literature search shows that 33.6% have shown increase when palliative care is being utilized. There been greater awareness among ICU nurses, among providers. Everybody's talking about, hey, what can we do differently? How can we help? How can we ensure that palliative care team is being notified appropriately? Do we have to wait till end of life? They're aware of all of that now. I noticed a nurse said, oh, I didn't know palliative care can be started early. I thought it was only till hospice care. I'm like, no, those are two different things. Palliative care come and help with symptom management. They help in early. They can intervene. They can assess the patient. They can also continue care after the patient is discharged. They continue to manage the patient's care, and they help manage the patients in general. For future plan, my future plan is for a broader policy integration, a longer term. I used a short time, 6 months, to do this project and only saw this amount of increase. Imagine if it's done a year or two. Imagine if it's spread to other chronic condition, not just COPD. We see a lot of patients with heart failure. We see a lot of patients with cardiac issue, cancer. We see a lot of patients. So imagine if palliative care for future is being implemented in also all these chronic conditions. It will better manage your case. Personally, since starting this project, since being in DMP, cause it's been a long journey, but I've learned so much. I've gained a lot of leadership skills, implementation skills, learning how to use data statistics, using SPSS. It's been a challenge, but this project and this DMP class, as well as DMP Essential, has shown me that a lot can be done when we use our voice, once we use our power, and we can use with evidence-based, show that we can do so much as nurses, we can do so much as individuals for the future. DMP education has empowered me. I started as a PSN nurse that they know so much. I was afraid to even talk to people, but now I go out and tell them about palliative care. I'm so passionate about palliative care and COPD and chronic conditions, and even seeing patients hospitalized. The same thing when there's been so much literature research that shows that with palliative care consult and palliative care screening, when integrated early, embedded in the system, helps manage their care. Thank you for listening, and this is my references. Thank you.